everyone in the room knows there were 922 overdoses in BC alone, and over 1,400 across Canada. And those are fatal overdoses. So while the opioid epidemic disproportionately is affecting men, we know that women are experiencing a particularly gendered impact in terms of the epidemic that's really compounded by and intersects with trauma, chronic pain, and addictions. And I was asked to speak for just a minute, and I'm going to keep it very brief given we're over time, just in terms of why this is so important from a women's health lens. And I think in terms of context, one thing to note, in late 2016, Vancouver Coastal Health released its first position paper on women's health and safety in the downtown east side. And this is in conjunction with and largely driven by women's health organizations, grassroots organizations in the downtown east side. And the report opens with a chilling and fairly frank acknowledgement that the current state and response, and this is verbatim, to women's health services and access to safe spaces in the downtown east side has been unacceptable for women. And we know that for the first step to really rectifying this is to ensure that a gender lens is applied across all design, implementation, and evaluation of health services and policies. And for the opioid crisis, we also know there are no boundaries in terms of income, class, and demographics, and I think that's somewhat unique to what we're seeing currently happening over the last 2 years. We also know that there are many legal and policy barriers that continue to be faced that really impede being innovative clinical and harm reduction approaches. So today we're going to be hearing from a leading addictions expert who's really working at the front lines of the opioid crisis. And I had the pleasure of hearing speak recently at an Oak Tree trauma-informed care event. And I think really brings a lot of this together in terms of understanding how we apply a gender lens. So Dr. Annabel Mead has been practicing addiction medicine for 18 years and has experience in concurrent psychiatric disorders and chronic pain management. She's a fellow with the Royal Australasian Chapter of Addiction Medicine, a diplomat of the American Board of Addiction Medicine, and a UBC clinical assistant professor. She's a past physician lead at the Hartwood Centre for Women, provincial residential treatment for women with substance use disorders, and she's currently practices as a consultant with St. Paul's Hospital. Dr. Mead is also the director of the new BC Centre for Substance Use Addiction Medicine Fellowship Program. So with that, I'd like to turn it over to Dr. Mead.
Thank you. Hi, I'm aware you're probably getting a little hungry now, so I'll try and flip through this as quickly as possible, but there's a lot of information I'd like to share with you. I will be referring to some published data, although there is far from an abundance of research on the nuances of opioid use by women. And I'll offer some personal insights based on my clinical experience from working in this field for some time. Fentanyl is pretty much a household term now. This photo from our local newspaper back in 2015 stated that that year appeared to be BC's deadliest year. As we know, the situation has worsened considerably since then. Fentanyl is a potent synthetic opiate, and the market here has been flooded with illicit fentanyl from China. This is processed into pills or sold as powder, cut into or mixed with heroin. Because it is so potent, it's very difficult for the suppliers to sell accurate doses, and the emergence now of multiple more potent fentanyl analogues, including carfentanil, really makes using street opiates a game of Russian roulette. Back in the summer of last year, Insight, our local supervised safe injection facility, found that 86% of drug samples offered for testing contained fentanyl. I have to say in our practice now, it's rare to find no fentanyl in urinary drug screenings of opioid users. This time last year, a public health emergency in British Columbia was declared, represented by the vertical line here. That was in April of 2016. At that stage, death rate from illicit drug overdoses had increased, had pretty much doubled. The aim was to enable a mobilisation of an immediate, coordinated response to curb the deaths and harms associated with fentanyl use. Despite this multi-pronged response, though, we see that we have seen deaths rise yet again to over 100 per month for the past 6 months. So I don't think this crisis is going away anytime soon. So what does the opioid epidemic mean for women in particular? Here are some of the faces of opioid addiction in this city. A typical downtown east side SRO or single room occupancy hotel. This is a photograph taken by a bystander on Hastings Street of a woman overdosed. It's a little hard to tell in this picture, but she's 7 months pregnant and required 7 doses of Narcan to revive her initially. And finally, the Laytons. This is a young couple from last year who together died from a fentanyl overdose in their new home whilst their 2-year-old son was being babysat by her mum. My point here, obviously, is that opioid addiction cuts across all socioeconomic, age and cultural groups. So this NIDA-funded Suboxone study from 2011 compared characteristics of men and women with opioid use disorder. 33% of the participants were women, which is pretty good in a treatment setting for addictions. And they found that women had more severe clinical profile as measured by the Addiction Severity Index. They experienced significantly more cravings and more intense cravings. They had more past and active medical conditions, and partly this is because women expose themselves more to health risk factors such as sex work and sharing injection equipment, thus having an increased rate of HIV and hepatitis C seroconversion. They were more likely to be unemployed, and they had much higher rates of past and current psychiatric symptoms. A similar study done in Australia on women that used heroin showed significantly higher rates of depression and suicide attempts compared to their male counterparts. So we do know that men have opioid use disorder at twice or maybe even 3 times the rate of women. But this again is data from our BC Coroner's Service, and we see that men are dying at a much higher rate than women. So in 2016, only 19% of the deaths were women compared with men. But we do see in the past 2 years that there has been a doubling of the number of deaths for women. We've little evidence to guide us as to why this might be, so I can only put forward a few ideas. I postulate that women are more likely to use with their partners or with others, so they may be more likely to be resuscitated in the event of overdose, whereas men are more likely to use alone. We've got to remember that this is overdoses ending in death. There are way more overdoses that are non-fatal. Perhaps in the context of intimate relationships, the male partner may be more dominant and may use available drugs first, and women may be more cautious in their use in general. However, we do know that women use prescription opiates more than men. So in that way, they may be somewhat protected from exposure to fentanyl, which, as we know, is driving this big spike in overdose deaths. So let's talk for a minute about prescription opioids. We know that there's a higher prevalence from the Canadian Tobacco, Alcohol and Drugs Survey back in 2013. That's the most recent Canadian data that we have. But in a study from Ontario, the majority of women entering methadone maintenance treatment across 16 different sites reported becoming opioid dependent from prescribed opioids. Women tend to be prescribed higher doses of opiates by their primary care providers and used for longer periods of time. We know that chronic pain is significantly more present in women with opioid use disorder, and certainly at Hartwood Centre for Women, at least 30% of women have a significant chronic ongoing pain disorder. Women are more likely to progress to dependence after initiation of drug use. This is likely due to underlying physiological differences, and as noted before, experience more cravings, which of course is one of the contributing factors to the difficulties in stopping using. Just quickly, this is US data which tables the significant rise in overdose deaths related to prescription opioids in the first decade of this century. That's the purple line at the top. And there you can see the pink line at the bottom, deaths related to heroin use. Of note in there, we were also seeing cocaine in the blue and antidepressants in orange, but that green line is benzodiazepines. That's another topic for discussion, but ongoing increasing death rate from benzodiazepines, again, prescription medication. So what's been our response to the opioid overdose in the past, the opioid crisis in the past 12 months? There's been a massive rollout of the take-home naloxone kits program. in our emergency departments, inpatient hospital wards, community health centres, pharmacies, and importantly in residential treatment facilities and support recovery houses, which is good to see. I can say that that is a high-risk time for overdose when someone has been in treatment and is not using. Often, especially if they're not being treated with pharmacotherapies, their tolerance drops, and on leaving treatment, very high-risk time for overdosing. So whenever anybody leaves treatment now, they should be going with a take-home naloxone kit. Vancouver Coastal Health has recently opened its 5th overdose prevention site in Vancouver. We've been working hard to improve access to timely treatment for opiate use disorder, and in particularly a big focus on the medication Suboxone, buprenorphine. The College of Family Physicians in BC, the College of Physicians and Surgeons in British Columbia has lifted the prescribing limitations for Suboxone. It used to be only methadone prescribers could prescribe, now any doctor in British Columbia. So we're really rolling out, trying to educate doctors and increase the uptake of this treatment with primarily primary care physicians, but also emergency docs. Suboxone and methadone are both now on Plan G, which means that any BC resident that earns under $42,000 a year can get medication for free. We have a number of new clinics. The Rapid Access Addiction Clinic through St Paul's Hospital is open to the community as well as the hospital, and Connections Clinic in the downtown east side, both low barrier treatment sites. And there's been an increase in publicly funded residential treatment beds. So this is a few pictures from the mobile medical unit, which was opened in December in the downtown east side in Hastings Street in response to the crisis. The whole idea was to take acute overdose victims brought in by ambulance so as to reduce the pressure on the hospital system and on the ambulance drivers having to traipse all the way across town to St Paul's Hospital, wait an hour and then go back again just to ferry the next patient across. So they would bring them, the relatively stable patients that had responded to Narcan would come into the medical mobile unit, and we could intervene with offers of detox and treatment and medication, etc. We also saw a lot of patients purely walking in looking for treatment, and after the first couple of weeks we were seeing on average 30 patients a day there. However, of these 30 presentations per day, about 10% were women. Many of these women, however, did present with their partners, and often there appeared to be features of intimate partner violence, power imbalances, and loss of autonomy for these women. I also saw quite a few girls from the recovery setting previously who had returned to their addictions. I saw one 21-year-old Aboriginal girl with her 19-year-old sister. She had overdosed, brought in by ambulance. The sister was absolutely distraught because she felt that it was her fault having left her sister for 20 minutes and came back to find her blue and not breathing. The two girls had just recently moved over from Sea Shelter and had no connection with any supports in Vancouver. In the downtown east side. In addition, the older girl had very significant signs and symptoms of sexual trauma. So in summary, the women that we did see through this mobile medical unit, there was an overwhelming flavour of ongoing trauma. So women appear to be underrepresented in treatment settings, we do know that. They face some shared but also unique barriers to accessing care. Women are often the anchor in the family setting, and admitting to loss of control over drug use can be hugely shameful for them. We know that they have very high rates of trauma, as Nancy alluded to in her presentation, and that's known to impede engagement and retention in addiction care. High rates, as mentioned, of PTSD, but also eating disorders, something that we forget to talk about sometimes, is a really significant barrier. Most women with any kind of significant eating disorder cannot be looked after in our traditional support recovery settings or residential treatment settings. Intimate relationships, often a woman is in a relationship with someone else that's also using, so not only does she have to get help for herself, she has to, find ways of leaving that relationship or engaging the partner in care as well. Residents of rural areas of British Columbia have very limited access to treatment. In the interior of BC, they actually had the highest per capita death rate from overdoses last year. Childcare issues obviously are a big problem, leading up to even fear of losing custody of children. And Aboriginal women struggle with the institutionalised feel of some of our treatment centres and the lack of traditional healing practices on offer. Trauma is often cited as a precipitating event for the initiation of drug use, particularly in women, and it can certainly increase severity of already established risky drug and alcohol use. There are some of the reasons that women use opiates, including chronic pain. I won't go into more detail there in the interests of time. So, implications for treatment. Optimising treatment effectiveness for opioid-dependent women across the life cycle of teenage, pregnancy, child-rearing and older age is very challenging. We need to be able to provide a range of pharmacotherapies, psychotherapies in various settings, obviously outpatient and inpatient, and peer support. And these settings need to be gender-specific and safe for women. Of course, we have to always provide trauma-informed care and culturally sensitive care. We need to support and treat the high rates of co-occurring psychiatric disorders, their physical health needs, and we really need to explore more ways for managing pain with non-opioid treatments. And of course, addressing collateral areas of functioning, vocational rehab, social rehab, parenting support. Prevention is key. We are not going to treat our way out of this epidemic. At a societal level, we need to employ strategies for minimising exposure to trauma in the first place. We need to educate our doctors around responsible prescribing of opioids for pain and reframe treatment of chronic pain utilising non-opioid treatments as much as possible. And my last slide, addiction is a paediatric disease, another one of my favourite sayings. 90% of people with severe addiction began their addiction in their teens or even their pre-teens. As we've identified, women progress more quickly to dependence after drug initiation, so we need to intervene early. SBIRT refers to screening, brief intervention and referral to treatment, and is a core component of our addiction medicine training. It's a model that helps routinely screen everybody, but particularly teens and young women, to identify substance use problems early before they progress to actual addiction, and then make sure that our healthcare workers and school workers have skills to provide evidence-based brief interventions on a timely basis. I'm going to leave it there for any questions. Thank you.
Great. So thank you very much, Dr. Mead. It was an excellent presentation and a really, urgent and chilling topic. So I think we have about 2 minutes for questions. Is that looking? Yeah. Okay. Great. So open it up for any questions for Dr. Mead.
Come on.
All right. Well,
They're too hungry.
Maybe I will ask a question. Is there one question over there? Great. I'll let you go ahead.
Just a brief question.
Yeah.
Thank you for the presentation. I was wondering, it looked very much that this is a problem of sort of downtown, east side marginalized women, but is that also a problem of women that we wouldn't otherwise think of being at risk, or is it not an issue?
A lot of my work is through St. Paul's and in the downtown east side, but when talking about providing pharmacotherapies, that is really a province-wide initiative that's being rolled out to everybody in terms of our training of doctors everywhere. But again, all of this has had to be done very quickly. It's still kind of early days, and I think that we're just seeing the beginning of this rollout. There's a big focus on pharmacotherapies because that is very evidence-based and very proven to help stop illicit drug use, which is our big problem at the moment, our big focus at the moment. So a lot of attention's going into that, and I think that's appropriate. But we do, but we do need to reach out to all areas and all primary care providers everywhere. But we do also need to look at all of those other things, prevention, but that's a much bigger picture. Yeah.
Hi. You mentioned that women who had past presentations of mental health often presented later on. And so what kind of past mental health presentations were there, like depression, anxiety, what was it?
To my mind, I mean, people love to label, you know, most people say they have generalized depression, generalized anxiety disorders, and PTSD. They're the three main ones. All of those really often trace back to trauma symptoms. So, you know, physiological and psychological adaptations to trauma. But very significant, and it's, you know, drugs are used to help mitigate and minimize those symptoms. So when you take the drug away, all of those things come bubbling straight back up. So we have to be very skilled at helping women manage that, because that's the reason the relapse rates are so high. Mm-hmm.
Thank you very much. I want to thank our speakers for this morning. What a tremendous way to start off the day, an incredible array of speakers, and I really want to thank you. We wanted to have an emerging issues, women's health issue, and so that was exactly what we wanted to understand. So Dr. Mead will be here for a little bit, so if people have further questions for her, please do go up and ask her questions, and ask any of the other speakers from this morning. Right now, we're going to go into lunch. We, not surprisingly, because it's such a great conference with such a great topic, we're running a bit late. So, but we are going to start back on time at 1 to hear Erica M. speak about knowledge translation, which I think we're all really excited to hear. So please help yourself to lunch, and thanks again to all our speakers. And the lunch is in.
I know, it's always hard when you know that you're behind.